Hello to all of our loyal CONNEXT friends. Thanks for joining us. It's 11 a.m. here on the Pacific Coast, so we'll go ahead and get started. For those who have just signed on, please give us a quick shout out in the Q&A box to let us know that we have a good connection. While you're doing that, I'm going to take care of introductions and housekeeping items. My name is Kendall Perry, and I'm going to be your host today. So welcome, welcome. We are scheduled for 60 minutes of content with 10 to 15 minutes of Q&A. We're going to play that by ear depending on how we do with time. Speaking of Q&A, you will have the opportunity to ask Dr. Lustig questions at the end, so please don't be shy. The questions box is going to remain on your screen, so please type your questions in any time. Also, if you have technical issues, let us know. Nicole and Lacey are working in the background to make sure that you guys all have a really great experience. Recording, we will send the recording later today via email with the CE information, and we will also post the recording in our Facebook group. Once you complete the CE quiz and evaluation, your certificate will be issued within about 1 to 2 weeks. So with that out of the way, it is my absolute pleasure to introduce our presenter today, Dr. Robert Lustig. I know a lot of you have been anxiously anticipating and awaiting this course today, so we are so excited. Dr. Robert Lustig is a pediatric neuroendocrinologist and also holds multiple professorship titles at prestigious universities across the country. His career has focused on the regulation of energy balance by the central nervous system and the pathogenesis of chronic disease such as type 2 diabetes. He's one of the leaders of the anti-sugar and real food movements to improve global health. Dr. Lustig is also the Chief Science Officer of Eat Real, a nonprofit dedicated to reversing childhood obesity and diabetes by impacting the global food supply. He's the Chief Medical Officer of Google, a platform that ties together the patient, the doctor, the grocery store, and the insurance company. And his resume is quite impressive, we must say. So Dr. Lustig is doing incredible work across the globe. You all are in for a real treat today. Speaking of treats, if any of you are eating a sugary snack right now, I'd suggest finishing it right away before you hear what he has to say about sugar. And trust me, you will thank me later on that. I also want to introduce another guest host that we have on the line. We have Dr. Cooch joining us. He's the founder of Carie Free and an internationally recognized speaker as well. He's published hundreds of papers on dental caries in dental and medical journals, and we're lucky to have him as our resident caries risk management expert. So Dr. Cooch, you know the drill. I will let you officially hand it off to Dr. Lustig.
Thank you, Kendall. And I just want to tell you, Rob, how much I appreciate you doing this today. I met Rob several years ago and have spoken on a number of dental programs with him. Have had the good fortune to get to know him, and he became a keynote speaker at a rendezvous meeting in Central Oregon, which, although it was in February, seems like it was a lifetime ago. And amongst all of his other characteristics, and if you haven't read his books, I strongly encourage you to do that, Fat Chance and the Hacking of the American Mind. And I would tell you this, when I talk about dental caries and risk factors, and we talk about how much sugar Americans eat, and that's the second biggest risk factor in dental caries, I always conclude that by saying, and I don't know how to fix that. It's the American diet, and I don't know how to fix that. Well, I got to tell you, here's somebody who knows how to fix it. He's leading the parade on fixing that. And, man, I applaud you so much. So welcome, Dr. Rob Lustig.
Thank you, Kim. We appreciate it. And thank you all. Welcome and greetings from a bedroom, random bedroom in San Francisco. I can actually see the Golden Gate Bridge out my window. So the big question for all of you is, am I in my underwear or not? And I'll let you ponder that as we talk. In any case, Kim has generously introduced the concept that dentistry and medicine need to get on topic together. For many, many decades, the doctors and the dentists and really the dietitians have sort of gone their own separate ways, and the only way we're ever going to solve this problem is if we all work together and, can agree on some basic precepts. And that's the point of today's talk, is that ultimately we are all barking up the same tree, and we need to join forces in order to get the cat down. All right, so I'm going to try to, I'm having trouble advancing, Kendall. I'm hitting my advancer, and it's not working. Oh, there we go. Never mind.
There we go.
I take it
You
back.
got it.
There we go. Now I got it. So first of all, I do have some disclosures. I did write these 2 books for the general public, Fat Chance, which is about diet and physical health, and The Hacking of the American Mind, which is about diet and mental and behavioral health. I'm also the chief science officer of a nonprofit called Eat Real, where we are getting real food into California schools. And believe it or not, we're actually even doing that in the midst of this pandemic. And I also want to alert you to a new book that will be strictly on processed food, which will be published in March by Harper Wave. Right now, the provisional title is Food, Pharma, Feds Fiasco. So it will be a science-based expose of the entire healthcare system and how we all got it wrong. So I hope you'll look forward to that. All right. So as I said, we've all sort of barked up the wrong trees, and it's time to bark up the right tree. And doctors and dentists are really battling the same issue, and let me try to pull those together for you. So first, let's talk about cariology. And I always feel strange talking about dental caries to dentists. It's kind of like bringing coals to Newcastle. But I'm really often surprised at how, sort of rudimentary your caries training in dental school is. So let's bring everybody up to speed. So first of all, everybody recognizes this. This is a common, prevalent problem. In fact, it's so bad that we can't field a fighting unit in the military because of Mountain Dew mouth. The problem is that we're also seeing Mountain Dew mouth in 18-month-olds. And this is something that I saw routinely as a pediatric endocrinologist in my clinic. So if you look at the prevalence of dental caries, it was actually a relatively rare occurrence throughout our recorded history from 3000 BC until really the Industrial Revolution, when things really picked up. And of course, the reason for that is the modern diet, but the question is, what about the modern diet? So in 1934, perhaps the most important and seminal debate on the issue of dental caries occurred in New York City at the Hotel Pennsylvania across from Madison Square Garden. And there were some luminaries on the panel, and some of them names you'll recognize. So on one side was the conservative theory, the hygiene theory, if you will, that clean teeth do not decay. And we had people like Hyatt, Walker, and William. These were luminaries of the field at the time. On the opposite side, we had the nutritional theory. That is, that caries are a manifestation of the internal metabolic milieu, which is set up by nutrition. And we had McCullum, Merritt, and of course the ever famous Weston Price. So on the one side, we had people who were very interested in the question of plaque and this hygiene issue. And there was reason to be concerned about this, and certainly over the course of the last several decades, more and more information has come out about what's happened within the mouth. And you can see from looking at calculus deposits from fossils and doing PCR, you can actually determine what bacteria lived in the mouth. And what you can see from this slide from a study done in Nature Genetics 2013 is that the blue, which is, let me actually pull up the arrow here. There it is, okay. So you can see the blue sort of went away, and that was Firmicutes. And Firmicutes is a denizen of the small intestine. In fact, it's one of the bad guys in terms of metabolic syndrome. It's an anaerobe, and it is, very high in people who are, have cardiovascular, type 2 diabetes, other diseases of metabolic syndrome. But you can see that Firmicutes was a denizen of the mouth, but it kind of disappeared as time went on. Conversely, what you also see is that the proteobacteria here in maroon sort of came out of nowhere and occupy things. So the question is, there's been a migration of bacteria from the mouth to the intestine over the course of time as our diet has changed. And the question is, why is that? So moving on, if you look at our current mouth flora, what you can see is that this guy here in purple, Strep mutans, which was never there before, is a relatively new, recent denizen of the mouth, only since the Industrial Revolution. And that's shown here on this slide. You can see that the diversity of the types of bacteria within the mouth only started going down since the Industrial Revolution here. And when you look at what that is, you'll notice that Strep mutans pretty much wasn't even there prior to the Industrial Revolution. But now it's a primary component of the mouth. Conversely, take a look at Porphyromonas gingivalis, which has been there all the way through. And that has its own sort of sordid story. And let me tell you that story real quick. We're not going to spend a lot of time on it, but I think it is kind of important, especially as we talk about the intersection between dentistry and medicine. So Porphyromonas gingivalis has been associated with Alzheimer's disease. And the question is, how does the mouth have anything to do with the brain? And there are potentially two possible ways that this might be a major factor. One having to do with TLR4, toll-like receptor 4, which is one of the things that basically acts as an immune suppressant in our bodies. It's also activated by vitamin D, which is why vitamin D is such an important immune phenomenon. By altering that TLR4, Porphyromonas can activate GSK3 beta, glycogen synthase kinase 3 beta, which can then alter the orientation of tau, which is one of the proteins in the brain that ends up causing Alzheimer's. And so you can end up with Alzheimer's because of these indirect immunologic changes. But even more recently, this paper came out, they actually have found DNA for Porphyromonas gingivalis in Alzheimer's disease brains. Now, how the hell did it get there? What is going on? Is it possible that bacteria from the mouth actually migrate along the trigeminal nerve and take up residence in the brain and ultimately lead to changes in the brain that lead to Alzheimer's disease? So this mouth-to-brain connection is an extremely important one, and we will talk about a different mouth-to-brain connection as we talk about sugar. On the other side, we had the nutritional hypothesis, and we had McCullum, Merritt, and Price. And what did they say? Well, here's data that Aubrey Sheehan and Phil James developed over time and showed that ultimately caries prevalence is an interaction between the age of the tooth, that is the exposure of the tooth, and the dose of sugar. So the longer the tooth has been post-erupted, as you can see here on this axis, on the z-axis, versus the annual sugar consumption here on the x-axis, ultimately leads to the amount of caries that one sees here on the y-axis. So that this is ultimately an interaction between our internal milieu and our environment. In addition, there's a log linear relationship between sugar exposure and consumption and dental caries, as you can see here. So very clearly, sugar plays a major role in the nutritional side. Why is this? Well, it has to do with this phenomenon, which again, you guys know better than I do, called the Stefan curve. And you'll notice that various carbohydrates will lower the oral pH, but the thing that lowers it the most are the fermentable carbohydrates, glucose, fructose, and sucrose, because that's where the lactic acid comes from. These guys up here don't generate a whole lot of lactic acid. In fact, starch can contribute to the biofilm and actually can be protective against the development of dental caries. But it is these monosaccharides and also the disaccharide sucrose that ultimately leads to karyogenesis. So the epidemiologic data says that starch plus low sugar actually leads to a low incidence of caries, whereas starch plus high sugar leads to a high incidence of caries, suggesting it's not the starch, but rather the sugar. And if you look further, you can see that it's starch plus sucrose that changes the dry acid weight, the total amount of protein, and the total amount of lipopolysaccharide, not the others. And also, I'm sorry about the formatting here, but you'll notice that sucrose here and sucrose plus starch are exactly the same, and they are very different from starch alone in terms of pH and in terms of eating away of the tooth. So in each of these cases, it would appear that you have to add a fermentable either dye or monosaccharide to the diet in order to get karyogenesis. Again, well known to all of you, but there's been a lot of argument about exactly which monosaccharide we're talking about. And it really does appear to be the monosaccharide fructose. So in 1939, McCollum, who participated in that debate in New York City, famously made this comment. It seems that were we to turn to a low-sugar, high-fat type of diet, such as is prescribed for diabetic patients, notice what it says here, high-fat diet for diabetic patients. Well, guess what? We are now back to that. And the former chief medical officer of the American Diabetes Association, Robert Ratner, has now become the chief executive officer of Virta Health, which is trying to use a ketogenic diet to reverse diabetes. So this is a major, major change in thinking in the general medical community. Yet it was there 80 years ago. So we might expect to have a prompt and marked reduction in caries susceptibility. This type of diet is practicable in many countries, but fats in many regions are considerably more expensive to produce than are starches and sugars. At any rate, we now know how to produce good teeth as respects structure and how to preserve them in considerable measure from decay. So, this Mountain Dew mouth, very clearly, we know what the cause is, and we know why it's going up in prevalence. And the reason is the consumer price index. So if you look at the mean consumer price index for all foods here in orange, okay, and now look at the fruits and vegetables, and you can see that they've increased in consumer price index double. In other words, things cost twice as much as they used to, versus processed food down here, which costs half as much as it used to. So very clearly there's been an alteration in our food system and food system economic structure to promote the consumption of high sugar, low fiber processed foods as opposed to real food. That's what's driving all of this. William Davis famously said in 1941, presaging the changes that were about to occur at World War II, we realize very well, however, that if sugar is the great offender in the cause of dental caries, as seems to be the case, we have a very difficult task ahead of us in making progress in its control by the reduction of sugar intake so far as the mass of people is concerned. Most people would prefer some decay rather than to eliminate the sweets. Well, I could stop the talk right now, and I think you'd all get the point. We should keep up the admonition and give the evidence as to its harmful effect on teeth. At the same time, let's hope our research workers discover a more practical means of controlling or preventing dental decay. Well, guess what? They did. Because in 1947, a third circle was introduced to this, and that was the tooth itself. And we learned about fluoride. Now, the reason fluoride works is because the amount of time that the tooth spends at low pH and that the demin is exposed to lactic acid is significantly decreased, and also because of the fluoride addition to the calcium hydroxyapatite makes it harder for the bacteria and the lactic acid to be able to lift the calcium out. So there are very good reasons for fluoride addition to diet and to water. So water fluoridation became the standard in 1945. Grand Rapids became the first city in the world to fluoridate its drinking water. Ultimately, during the 15-year project, researchers monitored the rate of tooth decay amongst the Grand Rapids 30,000 school children. And after just 11 years, Trendley Dean, who is now director of the NIDR, announced an amazing finding. The caries rate amongst the Grand Rapids children born after fluoride was added to the water dropped more than 60%. This finding, considering the thousands of participants in the study, amounted to a giant scientific breakthrough, making tooth decay, for the first time in history, a preventable disease for most people. That's not true. We actually know it was a preventable disease before the Industrial Revolution. But nonetheless, water fluoridation became the standard, and it didn't matter where you looked throughout the world. When water fluoridation came in, caries prevalence dropped. No argument. And when they added fluoride to toothpaste, as you can see here, caries prevalence dropped. And so fluoride became the standard, and we know that. However, over time, in the field studies with fluoride dentifrice showed only about a 30% reduction. Now, that's still better than zero. On the other hand, it's not 100%. The point is fluoride is an adjunct to therapy for caries. It has never been a primary therapy. So let's raise the dose of fluoride. As you can see here, a 5,000 part per million dentifrice, and you only get a 40% reduction. So we're basically topping out here, and there's basically been no movement in terms of caries reduction ever since the addition of fluoride. And you can see that here because over the course of time, from 1971 to 2004, in toddlers, risk changed almost not at all. And here in older children, 6 to 19, basically got cut in half. But you'll notice there has been no improvement ever since. And it doesn't matter if you're talking about toddlers or adolescents. We're not talking about low socioeconomic or high socioeconomic. We're not talking about black, Latino, or white. Basically, it's all true in every single demographic group. There's been no further reduction in prevalence. And this is a problem. And the reason it's a problem is because we can't field an army. So here we see stage 3 dental caries. And you'll notice that over the course of time, it's been going up. And you can't put people with stage 3 dental caries into the field for risk of dental abscess. Now, we know that we can do something about this. My colleague, Simon Thornley in New Zealand, did an experiment where basically all they did was change the food in schools in Yandara, New Zealand. And they had a control set of schools as well. And it didn't matter, 8 years old through 10 years old. Ultimately, the only thing that really made a difference was which school you attended. Did you attend the school where they had a real food policy, or did you attend the school that had anything you wanted? And that was the big difference in terms of dental caries reduction. Having said that, here we have the 2011 guidelines for caries risk assessment and management for infants, children, and adolescents by the American Academy of Pediatric Dentistry, the AAPD. And you can't read it, it's too small, but I will tell you that there is no dietary advice for any age group. Now, that will change with the next one, which has been in process since 2017. But as you can see, this has been a problem within the dental profession for a while. And this is the American Dental Association current practice guideline for non-restorative treatments for caries management. Take a look. Do you see diet anywhere? Not one. Nothing. Okay? That is the American Dental Association's answer to dental caries. No discussion of sugar restriction or removal. So the question is, why wouldn't the ADA want to prevent caries in those who are already affected? The point is that this is a very American phenomenon, because here we have the FDI, the Federation of Dentistry International. And this is their 2017 guideline. And you'll notice that the primary protective factor, a tooth-healthy diet, and primary pathologic factor, frequent consumption of dietary sugars. They got it. So how come they got it and we don't? Now, one thing that I don't want to spend too much time on, but you probably are aware of, this paper came out just about 9 months ago, in JAMA Pediatrics, looking at cognitive function based on urinary fluoride status. And you'll notice a negative correlation. Now, it's not a big one, but nonetheless, it's there. And so the question is, does fluoride have negative effects on the body? It's always been assumed to only be protective against dental caries, but could it have other effects? And obviously, there are many people around the country who are anti-fluoride. In fact, Portland, Oregon removed fluoride from its water supply. I don't know if that's right or wrong. I'm not a cariologist. The point is that we clearly need something better than what we have today. And the question is, why is it that we're stuck in this? And that's where industry comes in. This is work that my colleagues at UCSF, Kristen Carnes, Stan Glantz, and Laura Schmidt did. They looked at the food industry documents and found the data that showed, the paper trail that showed that the sugar industry actually influenced the NIDR back in 1971 to turn away from diet as a mode of therapy and directed the NIDR to spend its money on development of a caries vaccine. Now, it is now 50 years since then. How's that caries vaccine working for you? Point is, this is a major problem, and it has been ignored by the powers that be in Washington, and there are reasons why, and they have to do with industry. So, now that I've explained how the dentists have been led astray, let me now explain how the doctors have been led astray. So let's switch from cariology to cardiology. So let's start with diabetes first, of course, because diabetes is a major risk factor for heart disease. And type 2 diabetes is increasing all around the world. This is a paper that came out in 2001, based on 2,000 data from around the world. And what it said was that in 2000, there were 151 million diabetics walking the earth. And what was projected in 2010 was 221 million. This is a 46% increase for an projected annualized inflation rate of 3.88%. Now, this is not what we saw. What we actually saw was 285 million diabetics for an annualized inflation rate of 6.55%, a doubling over what was anticipated. And in the next 4 years, 2014, we were up to 422 million diabetics for an annualized inflation rate of 10.3%, a tripling. So under our eyes and with our all of our media attention and research and everything else that we were doing, we actually ended up increasing our diabetes prevalence. WTF. One way to interpret this is that doctors cause diabetes, and there's actually some truth to that, and I'll try to explain how. So if you take a look here at heart disease, you'll notice that the mortality from heart disease has actually gone down, and that's because of statins and stents and exercise and a few other things. But what's happened instead is that we've traded one disease for the other, because look what's happened to diabetes. And so diabetes is even worse than heart disease, because with diabetes, you're sick for 20 years on dialysis for many of those years, and you're chewing through even more healthcare resources, because with heart disease, you just keel over and die. So from a purely economic standpoint, this has actually cost money. Even though heart disease has gone down, diabetes has basically taken its place. And if you take a look at the costs, here's hospital costs in red, physician costs in green, and pharma costs in purple. They do not add up to the total costs that have been accrued. And the reason is because the rest of it goes to chronic metabolic disease, the care and treatment of things like diabetes and other diseases of metabolic syndrome. What we in the medical field have done is we have ignored two inconvenient truths. The first is there is no medicalized prevention for chronic metabolic disease. There is just long-term treatment. And it's not treatment of the disease, it's treatment of the symptoms of the disease. High blood glucose, lower glucose. High blood lipids, lower lipids. High blood pressure, lower blood pressure. Each of those is not the disease itself, it's the symptom of the underlying problem called insulin resistance and metabolic syndrome. The second inconvenient truth is that you cannot fix healthcare until you fix health. You cannot fix health until you fix diet. And you cannot fix diet until you know what the hell is wrong. And we have been barking up the wrong tree for the last 50 years, just as you have. And it's all basically on this slide. This is the sort of the seminal slide, and I think you all know this. If you all watch football, and it's still okay to watch football, at least, for the moment. I don't know for how much longer. This was a 2-minute video that aired on every football telecast in the year 2013, sponsored by Coca-Cola, called Coming Together. And this is a direct quote from that video. Beating obesity will take action by all of us based on one simple common sense fact. All calories count, no matter where they come from, including Coca-Cola and everything else with calories. Well, I don't believe in common sense. I believe in data. What the data say is something else entirely. What the data say is that some calories cause disease more than others because different calories are metabolized differently in the body, because a calorie is not a calorie. We can prove it with fiber. We can prove it with protein. We can prove it with fat. But the one we're going to use today, and I would go through these other ones if I had time, but the one we're going to use is the fructose versus glucose paradigm. Now, if you look at fat, this is a study that was done in 2017, published in Lancet, called the Prospective Urban and Rural Epidemiology Study. It was done all over the world, 17 countries. What you can see is that as fat goes up, mortality goes down. And it's total mortality and cardiovascular mortality, and it's saturated fat, monounsaturated fat, and polyunsaturated fat. Basically, all of them cause a reduction in mortality. The only thing that increases mortality is carbohydrate, total energy from carbohydrate, refined carbohydrate in particular. Now, people get, all fired up about red meat. And red meat does have an increase in diabetes risk and in heart disease risk. And you can see that here with a hazard risk ratio of 1.24. However, when you factor out the iron, which is an oxidative stress, the heme, and you factor out the branched chain amino acids, and you factor out the trimethylamine oxide, TMAO, which is a risk factor for heart disease that the bacteria in your gut make, in fact, the saturated fat really doesn't do very much. And the hazard risk ratio goes way down, and it's not nearly as significant. Poultry, not at all. And for fish, it's actually protective. So what I want to do is I want you to call your attention to this picture here. So what we have, I took this picture in a Rome restaurant window in 2016. We have Italian steak, and we have Argentinian steak, and down here we have USDA Prime Choice A#1 corn-fed beef. Now, what do you see? These guys here, they're homogeneous. They're pink. What do you see here? Lots of marbling. We love the marbling. Marbling is why our steaks can be cut with a butter knife. But that marbling is intramyocellular lipid. That marbling is muscle insulin resistance. This animal has metabolic syndrome, and that's why it went from birth to slaughter in 6 months, as opposed to these guys who are grass-fed, who went from birth to slaughter in 18 months. This is a matter of cash flow. So by growing them faster and by increasing the amount of fat within the muscle, okay, we get a cheaper, tastier steak. No argument. The question is, what happens when we eat that? It's happening to us too, for the same reasons. And the reason is because of branched chain amino acids, which are high in corn. So branched chain amino acids, BCAAs here, correlate with insulin resistance, as you can see up here. And the reason is because branched chain amino acids end up becoming alpha keto acids, which overwhelm mitochondria. And the mitochondria have no choice but to take the excess and turn it into fat. And that's how the fat gets laid down from branched chain amino acids, which leads to insulin resistance. And in addition, like I told you, trimethylamine oxide is a breakdown product of choline, which is high in red meat, and that also increases risk for heart disease as well. So there are reasons to be concerned about our red meat. If you look at other dairy saturated fat like dairy, turns out they're protective. Like I said, fat is protective. So this whole saturated fat issue is really a tempest in a teapot that was generated by the food industry very specifically to peddle carbohydrate. What about surrogate markers? So everybody's worried about LDL. And LDL does correlate with heart disease, and you can see it here, but take a look at the hazard risk ratio. It's about 1.3. 1.3 it's significant, but it's not enormous. Okay, a 30% increase based on high LDL. If you take the entire UK population and you take all the people under age 60 and you remove them from the analysis, so you only study people from age 60 to age 95, turns out LDL levels correlate with longevity. The higher your LDL, the longer you live. Why is that? If LDL is the bad guy, how come LDL predicts longevity in the over 60 age group? Now, there are a lot of things going on in the under 60 age group, so it makes sense to remove them. They also eat a shitty diet. They eat a crappy diet. The over 60 people actually got raised on real food and eat a much better diet. The reason has to do with the fact that LDL is really not the big problem. The big problem is triglyceride. And that's the thing that people are not addressing. And the reason is because we didn't have a medicine for triglyceride until about 2 decades later. So everybody got focused on LDL and statins. But the fact of the matter is triglycerides are a much bigger problem with a hazard risk ratio of 1.8 compared to the hazard risk ratio of 1.3. So what is triglyceride? Well, it's these two species right here. So chylomicrons occur right after meals, okay, based on the fat you eat from your meal, but they get cleared quickly. The one that doesn't get cleared quickly is this guy over here called VLDL, very low density lipoproteins. These are what you measure in the serum triglyceride, the fasting serum triglyceride. So if your fasting serum triglyceride is going up, that means your VLDL is going up. So where does VLDL come from? Turns out that's the fat that's made in your liver from sugar. So triglyceride and sugar consumption are basically the same thing. Now here's LDL over here. Here's HDL, which is the good guy. Okay? But it's the triglyceride here that's made from sugar that's the real problem in terms of hazard risk ratio. And that's shown in this slide. Because what you can see here is it's not about LDL cholesterol. It's not about what you measure in the lab. What it's about is LDL particle number. So if a particle is large, then it's going to have more cholesterol in it. But it turns out the large particles are not a problem. So here we have survival rates, okay, on the y-axis based on particle number. Okay? And you'll notice that if your LDL particle number is low, you have a high survival rate, whereas if your LDL particle number is high, you have an increased mortality, irrespective of what your LDL cholesterol is. So we're measuring the wrong thing. Now, the reason we measure LDL cholesterol is because it's cheap. This is about 15 bucks. LDL particle number costs about 500 bucks. And it's only done in specialized labs like Atherotech here in Mountain View. And insurance doesn't pay for it. So the question is, how do you know whether you have a high LDL particle number? How do you know if your LDL particles are large or small? So that's shown on this slide here. So there are two kinds of LDL particles. One is called pattern A, also known as large buoyant. You can see it here. Okay, and you'll notice it comes off the electrophoresis early on because it's large. These guys, turns out, are relatively cardiovascularly inert. They don't really cause heart disease, and the reason is because they're too big to fit under the surface of the endothelial cell when they go through the capillaries. And also because they float, because they're buoyant, and so they get carried along with laminar flow. Conversely, here's the bad guy down here. You'll notice these guys are small, dense. Those are called pattern B LDL. You'll notice they come off the electrophoresis at a different place. They're still all measured in the LDL cholesterol, but very clearly these guys are very different from these guys, and that's the point. So how can you tell with a $15 test which LDL you have, the large buoyant or the small dense? What you have to do is you have to look at the triglyceride. So if your triglycerides are high, that means your LDL, if your triglycerides, are low, but your HDL is high, that means that your LDL is the large buoyant or type A. Conversely, if your triglycerides are high, but your HDL is low, then you have type B, or the small dense. And you can see here are the large buoyants, and here are the small dense. These guys you don't have to worry about. These guys are pretty much cardiovascularly inert. It's these guys that matter. And it turns out these guys are what dietary fat raises, and these guys are what dietary carbohydrate raise. And that's why dietary carbohydrate is the big problem with LDL and with triglyceride. And you'll notice here in these studies that triglyceride correlates negatively with sugar consumption, positively with sugar consumption and negatively for HDL. So triglyceride goes up with increased sugar consumption, and HDL goes down with increased sugar consumption. So it's that triglyceride to HDL ratio, and that is a manifestation of insulin resistance. The more insulin resistant you are, the higher your triglyceride and the lower your HDL, and the more risk for metabolic syndrome. And you can see here's the meta-analysis of triglycerides with HDL. What about randomized control trials? So everybody's familiar with the Women's Health Initiative? No effect. No effect of low-fat diets on cardiovascular mortality. And if you look at LDL lowering as a primary therapy, turns out no benefit on mortality. And most of the trials didn't even reduce CVD events. And some of the drug studies actually reported harm. So using statins to get LDL down is really a complicated, dicey issue, to say the least. And we know that statins increase risk for diabetes because of how they work on mitochondria. So if your mitochondria don't work very well, you're more at risk for diabetes. And because of where statins work in the cell, in terms of 3-hydroxyglutamyl-CoA reductase, okay, that's a mitochondrial enzyme. So it's affecting mitochondria. If you don't believe me, believe the banks. Why should you believe the banks? Credit Suisse Research Institute came out and said, fat in the new health paradigm, here's what they said. A high intake of omega-6 fats, vegetable oils, have not been proven as beneficial for our health, and trans fats have been shown to have negative health effects. The higher intake of vegetable oils and the increase in carbohydrate consumption in the last 30 to 40 years are the two leading factors behind the high rates of obesity and metabolic syndrome in the United States. Saturated and monounsaturated fats are not. So why should you believe the banks when the doctors say something else? And the reason is because the banks don't have a horse in the race. They're transparent. You know what they're about. They want to make money. So they don't want to take what the doctors say as gospel. They want to know for themselves. So they did the analysis themselves. And they came to the conclusion that it's not about the fat. It's about the carbohydrate. My colleagues, Asim Malhotra, Rita Redberg, and Pascal Meyer, and these are not exactly lightweights. So Asim is a member of the National Health Trust of the UK. Rita Redberg is the editor-in-chief of JAMA Internal Medicine, and Pascal Meyer is the editor-in-chief of BMJ Open Heart. Okay, not exactly lightweights. And they published this editorial: saturated fat does not clog the arteries. Coronary heart disease is a chronic inflammatory condition, the risk of which can be effectively reduced from lifestyle interventions. And the primary intervention is get the sugar down. So we had published this Nature article back in 2012 called The Toxic Truth About Sugar. And Gary Taubes had written this New York Times Magazine article about our research at UCSF called Is Sugar Toxic? So when I say toxic, I mean it. You know, people say, oh, come on, really? That's just hyperbole. No, it's not. And the reason is because here's the definition of toxicity. The degree to which a substance can damage an organism. Anybody got a problem with that definition? That's the dictionary definition. Notice it does not distinguish acute versus chronic toxicity. So, of course, we have things like acute toxins like sarin and ricin and cyanide, you know, parts per billion, keel over and die, you know, in 5 minutes. Okay, that's not what we're talking about. We're talking about chronic toxins like arsenic or benzene or polyaromatic hydrocarbons or tars, you know, in cigarette smoke, or sugar. So in order for me to make my case, I have to demonstrate that sugar is an independent risk factor for mortality, that it is exclusive of calories and exclusive of obesity, because otherwise calories would be toxic, and we know that's not true. And I can't just do correlation. I have to show causation. So that's a different level of proof that I have to be able to bring to bear to make this statement that sugar is toxic. Now, there are a lot of critics of this. They say, well, you use only animal models, not human studies, and you have to give excessive doses of fructose. Okay, so I am going to limit my discussion today to human data only, human consumption only, and in doses routinely ingested by humans, and that are controlled for calories and obesity, to prove that it's the sugar stupid. So the mortality risk for sugar beverage consumption is enormously high. This is correlation, not causation, and it's higher than artificially sweetened beverage consumption. Okay? But the risk for artificial beverage consumption is slightly higher, as you can see here, not as high as for sugar beverage consumption. What I'm going to show is plausibility, mechanisms, correlation, and finally causation to make my point. So let's start with plausibility. And it basically is how sugar is handled by the liver. So over here we have normal liver. I don't know if any of you remember your histology from dental school, but you probably got to see this at some point. So these are sinusoids, normal liver anatomy. And, you know, you can see the blood flowing through the sinusoids, and here are the Kupffer cells, and, you know, this is the bile canaliculus here. And take a look over here on this side. What you see is you see fat vacuoles here, and you can see all the lymphocytes and the macrophages lining up, and you can see the beginning here of fibrosis. So this is called fatty liver disease. The question is it alcoholic fatty liver disease, or is it non-alcoholic fatty liver disease? So prior to 1980, if you saw this under the microscope, this was alcohol. But today, 20% of children have this, non-alcoholic fatty liver disease, because kids don't drink alcohol. Here's a way to remember this. This is an MRI Fat Fraction Map of an obese person. Notice the love handles here. But what I want you to do is take a look at the liver. Notice 2.6% liver fat, dark. Here, dark. This is a metabolically healthy obese person. Nothing wrong with this guy. He'll outlive you. Even though he's fat, he's healthy. And the reason is because his liver is healthy. Now take a look at this guy. Different story. Also fat. Notice the love handles here. But take a look at this guy's liver. 24% liver fat. This guy's got metabolic syndrome. And finally, take a look at this guy. Notice, no love handles. It's the thin guy. Okay, but take a look at his liver, 23% liver fat. This guy here on the right is just as sick as the guy on the center. Thin sick, fat healthy. And the reason is because it's not the fat you can see that matters. It's the fat you can't. And particularly the fat in the liver that you can't see. Turns out, non-alcoholic fatty liver disease is the liver manifestation of metabolic syndrome, and it's congruent with all of the other manifestations of metabolic syndrome. Large waist, high glucose, low HDL, high triglyceride, high blood pressure. This is what metabolic syndrome does to the liver, is non-alcoholic fatty liver disease. And of course, it's higher in the obese. No argument there. Obesity is a risk factor, but it's not a cause. And it's true in adults here on top, and it's true in children here on the bottom. It is a primary predictor of type 2 diabetes in the Korean population. 3.5 times more likely. If you have fatty liver, you are 3.5 times more likely to develop diabetes in your lifetime than if you don't. And I personally think it is the primary driver. And here, this is important for all of you dentists. There is a correlation between tooth disease, either periodontitis or caries, and non-alcoholic fatty liver disease. This is work Jane Weintraub did in response to a talk I gave at the American Academy of Public Health Dentistry. American Association, sorry, of Public Health Dentistry back in 2016. And so they went back and looked at their data and found, indeed, they found the same correlation between tooth disease and liver disease. Now, the question is, where did the fat come from in the liver? That's the big question. So, this is a study that was done at WashU St. Louis by Sam Klein's group, Fabrini et al. What they did was they quantitated the visceral adipose tissue, and they quantitated the liver adipose tissue, the intrahepatic triglyceride. And they asked the question, which explains the insulin sensitivity, the metabolic dynamics better? The visceral fat, belly fat, or the liver fat? And the answer was, when they held the liver fat constant, the visceral fat explained none of the difference, as you can see here. But when they held the visceral fat constant, the liver fat explained all the difference, as you can see here. So it's the liver fat that matters. Now the question is, where'd the liver fat come from? And that's over here on the right, in gray. Non-systemic fatty acids. The white is systemic fatty acids, but you notice those don't change. Systemic fatty acids, we know where those come from. Those come from either lipolysis of adipose tissue or diet. But non-systemic, that's what we're talking about. Where'd those come from? It turns out those are the ones made right in the liver from sugar. And so I'll show you that now. So here we have a liver cell, a hepatocyte. And when a glucose molecule enters a liver cell, it pretty much ends up at glycogen. Very little of it will end up going down the glycolytic pathway to pyruvate, enter the mitochondria, get burned up to oxygen and carbon dioxide and ATP. And very little of it will end up as citrate here, getting thrown off from mitochondrial overload. And very little of it will end up as VLDL right here. This reaction here in orange is called de novo lipogenesis, DNL, new fat making. So this is how sugar, glucose, say in this case, gets turned into fat. Now that fat usually gets exported out, and so your triglyceride goes up in your blood, and that will end up in your adipose tissue. And so, can glucose drive weight gain? Sure. And, you know, the more insulin that you release, the more weight you gain. So, glucose is a substrate for obesity, and I don't argue that. But that's not what we're talking about here. What we're talking about here is insulin resistance and metabolic syndrome. Now, let's take another carbohydrate. Let's take alcohol, ethanol. Turns out ethanol does not go to glycogen. Ethanol comes straight down to the mitochondria as acetate, gets turned into acetyl-CoA in the mitochondria. The mitochondria are overwhelmed by the alcohol bolus, throws off citrate, and now that citrate ends up as VLDL. And that VLDL will get exported out, and that's why alcoholics gain weight. But some of the lipid won't make it out, will precipitate as a lipid droplet, and now you have alcoholic fatty liver disease. And once you have that alcoholic fatty liver disease, now you have insulin resistance, because that fat is interfering with the function of that liver cell. And now the pancreas has to raise the amount of insulin that it makes in order to make the liver do its job. Well, here's fructose. You'll notice fructose The whole fructose bolus ends up in the liver, 100% of it. You see glycogen anywhere? Fructose doesn't get converted to glycogen. It all comes down here to pyruvate. The pyruvate ends up being metabolized by the mitochondria just like before. The mitochondria get overwhelmed, throw off citrate, and the citrate drives the VLDL. And you end up with triglyceride in the bloodstream, which can then serve as a substrate for either cardiovascular disease or obesity. And some of it won't make it out, just like with the alcohol story. Some of it will precipitate as a lipid droplet, and now you have non-alcoholic fatty liver disease. And when you have that lipid droplet, just like with alcohol, now your insulin receptor doesn't work. Now you have hepatic insulin resistance. That will raise your insulin levels because your pancreas is trying to tell your liver what to do. And so that will increase deposition of fat into adipose tissue. And insulin also interferes with leptin signaling that comes from the adipose tissue that's supposed to tell your brain you've eaten enough. But insulin blocks that signal, and so you end up eating more. And so what you now have is a vicious cycle between sugar consumption, the liver, the pancreas, and the brain to increase the amount of food consumed, all the while laying down liver fat and driving further hyperinsulinemia and therefore metabolic disease. Can we prove that? The answer is yes, we can. So let's start with correlative studies. Fruit juice consumption increases risk for type 2 diabetes, even when controlling for calories and for obesity. Sugar-sweetened beverages increase risk for diabetes, even when controlling for calories, energy intake, and obesity, BMI, 29% increase. There's a meta-analysis looking at sugar beverages and fruit juice separately. And you'll notice, controlling for calories and for controlling for obesity, you'll notice that adjusting for all of those things, the 95% confidence interval does not cross 1. It is statistically significant for both sugar beverages and for fruit juice. Yet we say fruit juice is good. No, it's not. This is a study we did where my colleague Luis Rodriguez, my dietitian, who's now my grad student, went and took the adolescent NHANES database for 3 cycles and calculated the metabolic syndrome in those adolescents and looked at quintiles of added sugar consumption across the NHANES database and showed if you use the first quintile as your reference range, so that's a odds ratio of 1 set there, mathematically. For each quintile thereafter of sugar consumption, the risk for metabolic syndrome goes up, unrelated to calories or weight. And you ultimately see a 10-fold increase in risk in metabolic syndrome when you reach the 4th quintile. We also showed it in an econometric analysis worldwide. We used the Food and Agriculture Organization, part of the WHO's database, looking at not consumption, but just availability within borders of countries around the world for a decade. What we showed was that only sugar explained the change in diabetes prevalence. If 150 calories per day per person were available within a country, diabetes prevalence only rose by a total of 0.1%, which is nothing. But if those 150 calories happened to be a can of soda instead, diabetes prevalence rose 11-fold to 1.1%. This study actually meets the criteria, the Bradford Hill criteria for causal medical inference, the same level of proof we have today for tobacco and lung cancer. We showed dose, more sugar, more diabetes. We showed duration, longer sugar exposure, more diabetes. We showed directionality, countries where sugar went up, more diabetes, countries where sugar went down, and there were about 10 of them, less diabetes. And finally, precedence. In order for something to be causative, it has to precede the other thing. 3 years. Whenever sugar changed in a country, diabetes changed in the same direction 3 years later. And we estimate, based on the math, that 25% of diabetes worldwide is explained by sugar alone. And finally, causation. This is work from Ron Kahn's group at Jaslin. Just came out in October. And what they showed was here's glucose here, here's fructose here, and they have very different effects on the mitochondria. Turns out fructose decreases beta oxidation because it gets in the way of the enzymes involved in beta oxidation. Well, if you don't beta oxidize, you turn it into fat. Glucose, on the other hand, enhances beta oxidation. So glucose causes the mitochondria to work better, and fructose causes the mitochondria to work worse. And this is what Ron Kahn, who's perhaps one of the most preeminent diabetologists in the country, this is his comment. The most important takeaway of this study is that high fructose in the diet is bad. It's not bad because it's more calories, but because it has effects on liver metabolism to make it worse at burning fat. As a result, adding fructose to the diet makes the liver store more fat, and this is bad for the liver and bad for whole body metabolism. We did a study here at UCSF that you may have heard about. What we did was we took 43 kids from our obesity clinic with metabolic syndrome, Latino and African American. And what we did was we figured out what they were eating at home on their home diet. We studied them on their home diet. And then for the next 9 days, we catered their meals. No added sugar. We took the added sugar out of their diet. Now, if you do that, we took their added sugar from 28% of calories to 10% of calories. We gave them fruit. Now, if you do that, you're going to reduce total caloric intake by 350 to 400 calories a day, in which case, after 9 days, you might lose weight. We didn't want them to lose weight. We wanted them to stay the same weight. Reason being, if they got better and they lost weight, people would say, well, of course they got better, they lost weight. We didn't want them to lose weight. We wanted them to stay the same weight. We wanted them weight stable. So we had to replace the 350 to 400 calories per day in sugar with something else. We gave them refined starch. So, in the vernacular, we took the pastries out, we put the bagels in. We took the sweetened yogurt out, we put the baked potato chips in. We took the chicken teriyaki out, we put the turkey hot dogs in. So we didn't give them good food, we gave them crappy food. We gave them processed food. We gave them kid food kids would eat. But it was no added sugar food. And we gave them a scale. And every day we'd call them up on the phone, what'd you weigh? And if they were losing weight, we told them, eat more in order to maintain weight stability. And then we studied them again on day 10. Here are 3 papers that we've written on this study. We've actually published a 4th, which I won't talk about. And we're in the process of writing up the 5th and 6th right now. So this is just telling you what I've already told you. All their fasting labs improved. Okay, you'll notice blood pressure down 5 points, glucose down 5 points. Okay, where's the glucose? It's in here somewhere. Okay. Triglyceride down 46%. LDL down. Fatty acids up because now they're lipolyzing. Okay, so, and lactate. Normally you're not supposed to have a lactate level. Their lactate went down. Okay? So these are all good things in terms of metabolic improvement. Here's their glucose tolerance test. Here's before, here's after. Lower glucose. Here's their insulin on the glucose tolerance test. Here's before, insulin resistance not coming down. And here's after. They're consuming more glucose, but they're more insulin sensitive. And the reason is because they're not consuming sugar. So, of course, we wanted to know what their liver was doing. So what we did was we gave them C13 labeled acetate, which gets converted into fatty acids, palmitate. So we can measure the rate at which the liver is making fat out of sugar. And you can see here, here's the fractional DNL before, here's after 10 days, cut in half. Now, finally, fat depots. Now remember, we didn't let them lose weight, right? We made them stay the same weight. So their sub-Q fat here, no change, 0, because we didn't let them lose weight. Here's their visceral fat, their belly fat, down 7%, which is good. but take a look at their liver fat, down 22%. And it turned out, so this is a cartoon of what we did. So fatty liver, fatty acids, triglycerides, VLDL, pre, 9 days of fructose restriction, liver fat down, DNL down, visceral fat down, VLDL down, and most importantly, insulin kinetics up. Their pancreases were making insulin better and more appropriately. We reversed their metabolic syndrome in 10 days with no change in calories and no change in weight. And this has now been independently confirmed by another group at Emory and UC San Diego. I'll pass this. This is not related. Okay, I'm just going to move past this here. Okay, because of time. So what the data say is epidemiologic and randomized controlled trials do not support a positive association between animal-based fat, LDL, and diabetes or heart disease. Red meat may be promotive of diabetes. I'm not saying it's not, but it's probably not, almost assuredly not because of the saturated fat. It might be because of oxidative stress, BCAAs, or TMAO. I'm not arguing. I'm not saying red meat is good, but it's not bad. It's not bad because of the saturated fat. And in fact, dairy actually is protective. Prospective correlational studies show an association between added sugar and diabetes, exclusive of calories or obesity. Econometric data show causal medical inference for added sugar and diabetes, exclusive of calories or obesity. And finally, the proof of the pudding, the intervention. A glucose for fructose exchange showed improvements in fatty liver, insulin resistance, metabolic health, and lipids in just 10 days. Now, just so you don't think I'm fructocentric, there are actually 4 foodstuffs that are metabolized by the mitochondria in the liver the same way. Trans fats, branched chain amino acids, alcohol, and fructose, they all cause metabolic syndrome. And the reason is because the liver is the site of energy metabolism. None of them are insulin regulated, and there's no glycogen pop-off because the mitochondria are overwhelmed. This is mitochondrial overload. So we have causation, not correlation, causation for sugar and 4 diseases: diabetes, heart disease, fatty liver disease, and tooth decay. We have correlation, indirect data for cancer and dementia. We're working on those. We're not there yet. And here's the denouement. You know, remember that NIDR paper, the one that my colleagues ferreted out based on the sugar documents? Well, guess what? They did it to us too. Okay, they didn't just do it to the dentist; they did it to the doctors. This is a paper that my colleagues Kristen, Laura, and Stan also wrote. Sugar Industry and Coronary Heart Disease Research, a historical analysis of industry documents. And what they showed was that the Sugar Research Foundation paid 2 Harvard School of Public Health scientists in 1965, the equivalent of $50,000 in today's dollars, to publish 2 papers to single out fat and cholesterol as the dietary cause of coronary disease and downplay the evidence that sucrose consumption was a risk factor. The Sugar Research Foundation set the review's objective, contributed articles, and received drafts. The funding and role was not disclosed. They did it to us too. The Sugar Association has been behind the subterfuge of the entire nutrition profession for the past 50 years. And it is only through research that we've been able to figure this out. The problem is you can't just get rid of the sugar because it's in everything. So, yes, sodas for sure, desserts for sure, but half of the sugar in our diet is in foods you didn't know had it. Salad dressing, yogurt, tomato sauce, ketchup, crackers. Bottom line, processed food. Real food is the only answer. Processed food kills. Real food saves lives. And, by the way, sugar's addictive. And I'm going to pass that. So I wrote this editorial a couple of years ago, Processed Food, an Experiment That Failed. This new book that will come out in March is basically a full treatise on this notion that processed food is an experiment that failed. And the reason is because processed food is high sugar, low fiber. Real food is low sugar, high fiber. And all diets that work worldwide are real food. So it doesn't matter if you're vegan or keto or paleo or Mediterranean or any other diet, okay? Any diet that works, it's because it's real food in the diet. Processed food is the problem. So is sugar public enemy number one? Trans fats used to be, but now they're gone. So yes, sugar is public enemy number one. My colleagues, Kristen Carnes and Lisa Barrow, published this just a few months ago in Lancet on the conflicts of industry between the beverage industry and dental research organizations and called for reform. And that needs to occur within the medical profession too. And we are trying to do that. I am a member of a consortium that is trying to change both Washington and London with a white paper. Okay, and here are my colleagues who are trying to help. Our targets are the AMA, the ADA, the AAP, the BMA, the BDA, the BPS. Unfortunately, there are a whole bunch of naysayers, and they're the ones that are funded by the food industry. So in conclusion, this is a public health crisis because it's an exposure. Even in normal weight people, the exposure is processed food. The food industry has adulterated our food supply for profit. They have bought off scientists and co-opted critics. Most of the checks and balances have been eroded, and government has been complacent and in some cases even complicit. And our best chances right now are education, lobbying business, and legal action. At UCSF, we have gotten rid of all sugar beverages from all of our venues, all our cafeterias, the Healthy Beverage Initiative, and it works. And it's cut sugar consumption in half in these people just by not having it at work. CDA, the California Dental Association, supports it, even though the ADA doesn't. I think type 2 diabetes should be renamed processed food disease. It's a teaching moment. Let's roll back the subsidies for processed food on corn, wheat, soy, and sugar. My nonprofit is delivering real food to schools. Did you know hash browns are a fruit, by the way? It's true. Okay. And finally, we need to take fructose off the generally recognized as safe list because it's not safe. So the goal is to neutralize Big Food's poisonous propaganda and ultimately see the end of Big Food. So with that, I will close, and I'm happy to take any questions with whatever time we have left. Thank you for your attention, and I appreciate the opportunity.
Thank you so much, Dr. Lustig. I've had the privilege of hearing you present a few times, and every time I hear you, I learn new things. And I know we were getting a lot of really positive feedback. People were very much appreciating everything that you covered. So we had quite a few questions come in. There was one that kind of went to the top of the list because it was asked multiple times. I think since we have a lot of dental professionals on the line with us, they're very interested to know what your thoughts are and recommendations for sugar substitutes. So a lot of our dental products have xylitol, erythritol. Right. Somebody even asked about stevia as well.
Right, of course. So the data show, and the data has now come in, the data show that the toxicity of one Coke equals the toxicity of 2 Diet Cokes. So sugar, artificial sweeteners are better than sugar, but not good. So you need to understand that. Now, so the question is why? If it's not fructose and it's not calories, how come artificial sweeteners are still a problem? And the answer is a couple of answers. One, we now know that artificial sweeteners tell the brain that sugar's coming, so you end up releasing more insulin. And if you release more insulin, you're going to drive more energy into fat, and you're going to drive more weight gain. So you're going to end up with morbidities related to that. In addition, we know that artificial sweeteners alter the intestinal microbiome. So sucralose has been shown to lead to leaky gut, which causes inflammation. And that leaky gut is then those antigens end up at the liver, cause hepatic insulin resistance as well. So it's not that artificial sweeteners are good. They're not. They're just less bad than sugar. So the way I look at artificial sweeteners is the way I would look at methadone compared to heroin. Okay? So you have a heroin addict. That's bad. Okay? So you put them on methadone. Why? Okay, because it has a long half-life. It's an opiate. It keeps you addicted, but it's got a long half-life, so you don't crash. And if you don't crash, you don't steal a car. Now, the goal of methadone treatment is to wean people from the methadone over time. If you're going to use artificial sweeteners to wean people off sugar, that's fine. That's a great reason for using them, is to get people off sweet. But if the goal is just to substitute, that's not a very good answer. And the data show that consumption of artificial sweeteners and metabolic syndrome go hand in hand. And it may be because people are still consuming sugar because they're still addicted in other forms, or it may be because the artificial sweeteners generate insulin responses and insulin resistance by themselves. Either way, it's a problem. So if you're going to use artificial sweeteners, use it for the right reason, not the wrong one.
That's great. Thank you. I think that gives everyone a lot of good information on where to go from here with that. One other question, I think we'll have time for one more, and then we'll wrap up. I do want to say, beyond today, if you have more questions, Dr. Lustig has a website, robertlustig.com, that's full of resources. I would also encourage you to buy his books. There's a lot of great information in there, too. So one last question to end on here. How much of metabolic syndrome comes from genetics versus diet, if you were to put rough percentages on it?
Right, so that's been looked at, GWAS studies, genome-wide association studies. Bottom line, about 15% of metabolic syndrome can be explained by genetics. The rest of it they call dark matter. That's because it's diet. Okay, so the environment explains the other 85%. So if you look at the data, and I have looked at the data, the contribution of genetics to metabolic syndrome, it's there, but it's actually pretty minor. And you can't do anything about it anyway. You're not going to fix genetics. But you can fix the environment, and you can fix diet. And the easy thing to do is get rid of the sugar. And that helps at so many different levels. The problem is that all the food's been spiked with it. So people have to know that that's what they're trying to avoid. And the only way they can truly avoid it is by eating real food. But the problem is they think Cheetos is food. And as long as you think Cheetos is food, there's no way in the world you're ever going to fix it. So that's where the public education has to come in. And dentists can be that primary point of contact in terms of education, because ultimately that's in your best interest also, because oral health and systemic health are now virtually one and the same thing. We didn't even talk about obstructive sleep apnea, and that's a whole nother dental/metabolic connection. That's an hour unto itself. But I promise you, if you get the sugar out of the diet, you get the weight down because you got the insulin down, that OSA is going to get better.
Great. I wish we had another couple hours. I'm sure people would appreciate that as well. Dr. Cooch, did you have any comments that you wanted to add in here?
Rob, I always love your presentations. And I have to say a couple of notes I took here that really stand out. Number one, I'm just embarrassed as a dental professional that the ADA does not recognize diet as a non-surgical treatment for dental caries. We don't even mention it, and that for me personally, I feel embarrassed about that. Obviously, that's something we should be talking about. The only other last comment I'll make, Rob, is one of the things that I've learned from you, which sticks with me just all the time, when we talk about the difference between ultra-processed food and real food. If it comes with a label, consider it a warning label, because real food doesn't come with labels, right? A banana doesn't have a label on it. So I think, if we could help develop that mentality to understand, just all of us, that it's like, just focus more on eating real food and try and get the sugar out of your diet. And you're right, Rob, we as dental professionals, dentists and hygienists, assistants, we have such a huge opportunity to help educate our patients and discuss diet, because it does affect us in our profession directly in terms of, oral disease. So we've got a lot of work to do, but I really love having somebody like you on our side helping us out. So thank you, Rob, so much.
My pleasure. Look for the book in March.
Okay. Oh, got it. Next in March of 2021.
21. Yep.
Okay.
Look for the book.
Right
now the title is Food, Pharma, Feds Fiasco.
There you go. That sums it up.
I like it.
All right. Well, thank you so much,
Great.
Robin. Thank you, everybody, and thank you, Kendall.
Yes, you're welcome. For everyone, just one last item before we wrap up. For tomorrow's course, do not miss it. We're excited to host our very own Dr. Cooch. He's going to be discussing the latest research on infections and the use of sodium hypochlorite as a pre-rinse. So as dental offices start opening back up in some states, this new science will become critical in making sure that we stay safe as dental professionals and keep patients safe as well. So thank you all. Thank you, Dr. Lustig. Everyone have a great rest of your day, and we'll see you tomorrow.
Bye-bye.